Welcome again to a new presentation, and in this presentation we're going to have an idea about the cone beam CT machine. Do you really need to buy or purchase a machine for your practice? Let's have an idea about the need for investing money. These machines are not cheap to buy, so if you need to buy one, then you have to have a proper revenue so that you would buy one. Before this, do you do the procedures in the clinic that really necessitate buying one? Okay. Before we go into the needs and justifying the needs, we will have an idea about an important characteristic of the CBCT machine is the field of view. Field of view is the area of interest, or sometimes you will find it as ROI, to be covered during the scanning procedures. So how much you want to cover from the patient's structure. CBCT systems can be categorized according to the available field of view. These machines could be characterized as being of a localized region, approximately 5 centimeters coverage, 5 by 5 centimeters, and this will be termed as the dentoalveolar or temporomandibular joint. So you need to collimate the beam to the area that you need. You can have it increase the field of view to 5 to 7 centimeters. Say you want to have the maxilla or the mandible separately. You can have it also as an inter-arch machine that you will have a coverage of between 7 to 10 centimeters, like the mandible, and superiorly to include the inferior concha. And some bigger machines also are available, where you can have a maxillofacial use or maxillofacial coverage, and here you will have a 10 by 15 centimeters, and the largest ones which are available are the craniofacial ones. These would guarantee a coverage more than around 15 centimeters, that is from the lower border of the mandible to the vertex of the head. Okay. This is an image where you can see parts of a cone beam CT, and here you can see that this is a 5 by 5 centimeters. Here you can collimate the beam to an area where it only fulfills your needs. Suppose you're doing an endo treatment, or you're doing a surgery in a limited area. So some machines, the new ones, can offer or gives you the possibility of reducing the beam so that you will have cover only the area of interest that you want to see, like or you're suspecting a fracture, or you're suspecting a lesion in a buccal or a lingual plate. Of course you will have it in a 3D reformatted image, and you can see it from the axial, from the top. You can see it from the side, that is the sagittal view, and as well you can see it from the front, which we call it the coronal view. Other machines, which are called as the craniofacial machines, these would cover larger image or larger field of view, depends, 15 by 17, 15 by 15 centimeters. So machines, again, as we said, they are categorized according to the area of coverage that you want to see. In other words, how much of a patient structure you want to see, from the smallest to the largest possible, and this you can tailor this, or the needs can be tailored according to your practice.
When we talk about the
the need of buying or purchasing CBCT machines, actually we can describe it in another way, is that what are the guidelines of patient referral for the CBCT machine. If you look at this or the guidelines, it gives you an idea about your needs. So those guidelines are customed based on our needs. Okay? There are so many guidelines that are present in the literature. Each guideline or guidelines is according to a certain specialty in dentistry. There are guidelines for endo, there are guidelines for ortho, for surgery, for TM joint, for the maxillary sinus. So you'll find it scattered. If you go to the European Commission Radiation Protection, okay, you will find that these are actually not new. They are produced or released in 2012. These guidelines are actually a comprehensive type of guideline that houses the whole needs of that contains all the disciplines of the dental practice. I would suggest that you go back to this reference to further have a further idea about the needs. Again, as I said, you will find, if you are interested only in endodontic treatment, for example, there are lots of guidelines for referring patients for endo treatments. Before we go into the needs, it is very important that you have to have a justification. Justification, it means that there should be a benefit, a potential benefit, why the patient is exposed to radiation. There is benefit and there is a yield or a result. You are exposing your patient to high doses of radiation in CBCT, so there should be a justifiable outcome of exposing the patient to this high dose, whether in terms of treatment or diagnosis. So all CBCT machines must be justified on an individual basis. There is no justification that fits everybody and fits every case has its own justification. The potential benefits to the patient must always outweigh the potential risks of exposure radiation. CBCT exams should add new information that aids in patients' management, whether in terms of diagnosis or in terms of treatment. Of course, when we go to the referral criteria, and the referral criteria, CBCT should not be selected unless a proper history and clinical examination be performed. You cannot, or it is not justifiable to refer a patient directly to the radiographic examination. This should always be preceded by proper history taking and then clinical examination. If you feel that the clinical examination and the history taking were not enough to come with a proper diagnosis, then you refer your patient to the CBCT. Routine or screening of the patient is unacceptable practice. The referring dentist must supply sufficient clinical information, means clinical history, patient's history, and results of examination to justify the radiation exposure. This is in case if you're referring your patient to another radiologist. Soft tissues, unfortunately, when you're trying to have an idea about the soft tissues, CBCT machines is not your game. If images of soft tissues need to be seen, then you have two options. Either you refer a patient to a CAT scanner, that is computerized axial tomography, or to MRI, MRI being the gold standard. If you want to see the soft tissues, CBCTs will be the imaging method of choice of assessing of hard tissues. See, imagine the CBCT as an OPG, but it's three-dimensional. Do you see any soft tissues in the OPG? You see shadows, but you cannot differentiate between like salivary glands, tongue, muscle, lymph tissue. You cannot. You see it as a gray shadow. This is exactly the same in the CBCT. So it is dedicated for hard tissue examination. Why is this? Because the method of acquisition of the X-ray in the CBCT is different from the CAT scanners. The doses of the CAT scanners are much higher, so the attenuation can be varied between the soft and the hard tissues. In the CBCT, the dose is lower, so X-rays are attenuated or captured or stopped by the hard tissues, but soft tissues will just allow them to pass. This will create a shadow, but the shadow is not definitive. Intraoral and extraoral conventional radiograph should be the first approach in the diagnostic and the treatment imaging. If a patient needs any kind of treatment, we would advise that the intraoral, your first line of X-ray examination is the intraoral intraoral X-ray. If this is small, then you go to a bigger one, which is the OPG. Those are always, or those imaging modalities, they have always a lesser amount of radiation, and most importantly, they have better resolution compared to the image of the CBCT. So it is always advised that you start, your first line is the intraoral OPG. If you feel that you cannot visualize the lesion or a tooth, whatever, in the three-dimensional, then your next choice will be the CBCT. Now let's come to caries and periodontal disease. CBCT is a absolute contraindication in the method of caries detection. Your gold standard here is naturally the bite ring radiograph, especially if you are chasing the interproximal caries, early interproximal caries. There is no need, there is no justification whatsoever, whether you are using a large field of view or small field of view, that you will expose your patient to detect caries. This is for the proximal caries. Occlusal caries and small buccal and lingual caries and segmental caries, no way you can refer your patient to the CBCT. CBCT is not indicated as a routine method of imaging periodontal bone support. Again, the gold standard here is for initial lesions is the bite ring, and if it is an advanced lesion, then the intraoral periapical radiographs. Again, they will give you an image of a better resolution. The smallest, if there is a need for like a periodontal surgery, you're not aware of, you want to detect infrabony pockets or defects, and then you cannot, you feel that there is no other way of detection of these pockets, then if you are going to go for the CBCT, then choose the CBCT with the smallest field of view. The smallest one in the market now is 4 by 4 centimeters, 75 microsievert, 75 microns, the voxel size, which gives a high resolution. Which the high resolution, by the way, is always less than in a periapical radiograph. So, if you feel that there is no way but referring your patient to a CBCT, then go for the smallest field of view for detection of intrabony pockets, the furcation lesions, if you feel that the clinical or conventional clinical examination and radiographic examination do not provide the information needed for the management. Endodontics. In endodontics, again, CBCT is not the standard method of identification of periapical pathology. CBCT is not the standard method of identification of the periapical pathology. Your best choice here is a periapical radiograph, well taken, well done, well exposed. It will give you the periapical lesion coverage. If you feel that this is not enough to show the whole lesion, then you will go for the OPG. You will sacrifice some of the resolution. If again you feel that there is, like in cases of different cases, sometimes you feel your intraoral 2D dimensional radiography fails to give you the proper image, then you will go again to the smallest field of view. The idea here is that we want to keep the exposure to the smallest size possible. The smaller the area you expose, the lesser is the patient exposure. Of course, the lesser is the radiographic hazards to the patient. CBCT is not indicated the standard method of demonstration of root canal anatomy because again root canal anatomy can be better felt with with your tactile sensation with a small reamer or a file, and our colleagues, endodontic colleagues, are well aware of this fact. If you decide you will go for a CBCT, then choose, as we said, the smallest field of view. If in cases like excuse me, root canal anatomy, especially in multi-rooted teeth, where you feel that it's almost very difficult to view the anatomy. If in cases you're going to do endodontic surgery and you suspect proximity to some vital anatomical structures, say the inferior dental canal, the maxillary sinus, any lesion or any structure that might be affected, and then you feel that there is a danger of affecting this anatomical entity by your procedure and the intraoral radiograph failed to show you this, then go for the CBCT. If you suspect or there is an established root resorption, perioendo lesions, perforations, and atypical pulp anatomy, these are situations in which you may have a justification to expose your patient to CBCT, taking into consideration that you have failed to do this in the periapical radiograph and you have chosen the smallest field of view. So, surgeries and suspected root resorption, established root resorption, perioendo lesions in which you don't know which is the cause. In cases of impaction, if the low-dose conventional dental radiographs, the periapical, the OPG, the occlusals, fail to obtain the information adequately, then CBCT will be your next way of examination, radiographic examination, to localize and assess the impacted teeth. Of course, there is the including of the resorption of the adjacent tooth or teeth. Okay? Again, you have to use the smallest field of view compatible with the situation. You don't need to cover more than the area that you need. to reduce the radiation dose. The use of CBCT offering large volumes like the craniofacial one or the mandible, the whole mandible, or the other lesions, other sizes is contraindicated here. Preferably better not to be used, because you again consider exposing unnecessary areas that you would have otherwise seen them by normal lesser radiation to the exposure. CBCT may be indicated if conventional radiographs show a direct relationship between the mandibular third molar and the mandibular canal, like a change in the course of the inferior dental canal, severe or deep radiolucency of the apex of the tooth, or narrowing of the inferior dental canal. All these radiographic signs show clear intimate relationship between the apex of the impacted tooth and the inferior dental canal, and you feel that there is that your intraoral periapical radiographs fail to do or give you the proper relationship, then go for the CBCT. Trauma. Cases of maxillofacial fracture assessment, CBCT may be indicated as an alternative imaging modality to the CAT scanner. I would say that in cases of trauma, whether involving the teeth or involving the alveolar bone or the maxilla and the mandible, CBCT is indicated.